Good evening. My name is Dr. Clement Nka. I'm going to be talking today about a protozoan. This protozoan is known as Toxoplasma gondii. It actually is responsible, or it is a causative agent of a condition known as toxoplasmosis. And this is it's a very striking condition in the sense that it appears as conditions like seizures, conditions like jaundice, conditions like epilepsy, repeated seizures. This is the type of condition that takes us by surprise, in the sense that a young guy will do everything, study, graduates at university, and just when he starts working, he gets this good job, given a company car. But in one meeting, this youngster, can be a young lady, starts with a very bad seizure right in the meeting. And then what is bad about it is that the seizure itself is in a very embarrassing condition, in the sense that no one wants to urinate unawares in public. But this is what happens. And this embarrassment, he wakes up from this convulsion, he wakes up, or she wakes up wet. So this uncontrollable urination is very much embarrassing. And nobody ever knows what is the cause of this. People will just say, oh no, take him to the epilepsy clinic. Oh well, there he'll be given epilim, carbamazepine, and that will be it. He'll stay on that. And nobody will really come to say, what causes this? Well, this condition is an acute condition, or an acute state, and a chronic state, sometimes referred to as the latent state. The acute state is characterized by trophozoites. That's the characteristic of an acute state or an acute condition. In other words, toxoplasmosis, that's acute. It is characterized by trophozoites. Whereas the chronic condition or the latent condition is characterized by oocytes. They've got cysts. And these cysts are deposited by, there's this fecal oral infection or contamination that's done by cats. Cats will drop these oocytes. Cats. And the problem with cats is that they will deposit these oocytes and they will stay for 4 days without being active. On the 4th day, they start being active. So that if now an oocyte is swallowed by humans, they have got an infection of Toxoplasmosis. In fact, they've got an infection of the Toxoplasma gondii, and the condition coming from Toxoplasma gondii is known as Toxoplasmosis. So this is what happens. It can be shall I say, it can be a localized condition. Localized condition, it will be seen by fever, headache, sore throat, all the fatigue, all those. That's a localized condition. But it can be a disseminated condition, can be a generalized condition. Some people refer to it as a fulminating condition. Fulminating. Disseminated. And you get this with the newborns. Because number one, newborns don't have an immune system. They have to develop an immune system. So this infection just goes unhindered with infants. Remember the type of immune system that they have are the circulating antibodies, the maternal antibodies, but they don't have anything of their own, and so this disseminates very, very fast. And so it's a fulminating condition, and a disseminated condition, a generalized condition. And the other patients who are normally victims to this are the immunocompromised patients, like the HIV infected patients. Immunocompromised, you get it, the infection becomes a generalized one. And this is odd in the sense that if this infection takes place in the first trimester of pregnancy, you are sure to get a stillbirth. The first trimester of pregnancy, you're sure to get a stillbirth. But there are survivors. Those who survive, 1/3 of them, those who survive, they get what is known as congenital toxoplasmosis. In other words, the infants are, or shall I say, the infants are born. They are born with this condition. They're born with this condition. And once they are born with this condition as congenital toxoplasmosis, then what do you expect? You expect hydrocephalus. You expect microcephalus. You expect seizures. You expect an uncontrolled sort of fever. You expect ocular toxoplasmosis characterized by retinitis, retinal choroiditis. These are inflammations of these areas. Retinal choroiditis. And the retina, that's a light sensitive layer of the eye. And being a light sensitive layer of the eye, this inflammation is no good. And then there's something that develops there. Blind spots. Develop blind spots. Started with blind spots. They're called scotoma. It's a scotoma when it is one. Scotomata when there are many. And if you develop these scotomata, these blind spots on the retina, how do you expect the vision to be like? The vision becomes blurred. They get a blurred vision because of these scotomata. These blind spots which are there, on the retina, which are just on the retina, the light sensitive layer of the eye. So there's this ocular toxoplasmosis. This is, it's normally addressed. People they can at least get rid of the inflammation. In other words, the retinitis or the retinal choroiditis. They can try to do that using prednisone. Prednisone is anti-inflammatory, so it will go against. And vision tends to improve, but there's something that doesn't improve at all, and that is the visual acuity. Visual acuity is the clarity of vision. The clarity of vision does not improve. And how do we expect it to improve? Because the scotomata are there. They have not been removed. The scotomata are there, the blind spots on the retina. So if you have those blind spots, they'll remain there. And these patients, they go to an extent of being blind. They go blind. We're talking ocular toxoplasmosis. So, with the immunocompromised patients like HIV infected, they sometimes don't see because of this scotomata. Sometimes don't see. They lose vision for some time. This is a problematic situation. And when they are, I said, they are localized and they can be generalized. In other words, they can be fulminating, they can be disseminated. So if you have a disseminated, infection on the retina, how do you expect the patient to see? Blurred vision, and they lose vision. They lose vision altogether. These are the patients who develop hydrocephalus. If the central nervous system is actually attacked, they develop hydrocephalus. They develop microcephalus. They develop, cerebral calcifications, and that's what gives rise to these seizures. They get seizures, and they get repeated seizures, and these repeated seizures are actually called epilepsy now, because the repeated convulsions, these patients, they get that. And it's such a sad thing when they are job hunting, and they even get these jobs, but they notice that they don't qualify. They don't actually qualify. A young person will say, man, I don't know what's wrong with my vision. I don't know what's wrong with my vision. And we don't know. That time we say there's nothing wrong, there's something wrong with the vision. We don't know that there's a deep lying infection, and that of Toxoplasma gondii. Nobody's looking at that. And it's only one time when a healthcare worker says, no, man, I don't understand. There's a disturbance of central vision. Yeah. There's a disturbance of central vision. What could be the problem? Man, let's do a brain CT scan. Let's do an MRI. This magnetic resonance imaging. Those are very helpful tests, and the brain CT scan, because they'll be able to localize. They'll be able to say, here is a center. Here is a cerebral calcifications. They'll be able to isolate those cerebral calcifications, which were a response. It was because of infection by Toxoplasma gondii. And that's what is responsible for the seizures, the convulsions that we see, and we see a repetition of them, and called epilepsy. And this is something that comes late with some patients. For instance, if the infection, well, we say, if the infection takes place in the first trimester of pregnancy, we say you're sure to get a stillbirth. But there can be some survivors, and those will a third of them will have what is known as congenital toxoplasmosis. Others, they are the ones who will live until adulthood, until they get to a stage when they look for jobs and all that, and then they start convulsions. They start with convulsions, start seizures. And then that's when you start seeing that there's something wrong, and you do your brain CT scan, you do your MRI, and you notice that hydrocephalus, microcephalus, cerebral calcifications. Oh no! This is the type of thing that, and then you see that this is controllably only if you have to actually start treating now, man. And how would you treat it and try and stop this? Okay, the inflammation, you can use prednisone, and then inflammation will be taken care of, and that's and it improves the vision. It improves vision, though it will not take away the visual acuity. It will not improve the visual acuity. In other words, it will not the clarity of vision. It will not. But it will do something towards. That's known as ocular toxoplasmosis. And once you have that, some patients, they lose their vision altogether. And this is odd. And people will not go into. People will just treat whatever the patient is presenting with, like epilepsy, for instance. Send the patient to the epilepsy clinic, and give him the carbamazepine, give him the epilim and all that. But it's only when you go back and say, man, let me check this brain. That's when you start. You can only do you do that by using your brain CT scan, your MRI, and all that. But treatment, what do? You give them sulfonamides, and pyrimethamine. But one has to notice that the sulfonamides, they have one problem, that of causing these blood dyscrasias. So one has to check the hematology, has checked all these, check the HP and all that, all these indices, these blood indices, and check, but the pyrimethamine has got another problem, that of suppressing bone marrow suppression. So one has to be careful when using these, and try to use senior people in your department, your specialists in the area. Try to use them, but you know that sulfonamides are going to help in stopping this, though there will be these blood dyscrasias. But the sulfonamides, the pyrimethamine, will be working very, very well to suppress this toxoplasmosis, as a condition that comes from Toxoplasma gondii, the protozoan. So these are what you need. One needs to know something about the causative agents, and when you think of oocytes, the oocytes are spread around by flies. The flies, they transport these oocytes, and that is why it is so very much important that flies must be away from your food, because you ingest these oocytes, which are transported by flies. And also, there's this fashion. Get to a restaurant and you say, man, people respect you if you say, no, I'll have I'll have half done meat. Half done meat. The problem is, if there are oocytes in that meat has got to be cooked properly to make sure that there are no oocytes which are to be ingested by you. And the oocytes are there in the tissue cysts. There are tissue cysts, those are the oocytes. And if you ingest them with half-cooked meat or not cooked meat, so this is a problem. So you know that you get respected for ingesting something. I'm having half-done meat. No, man. No, let it be done well if you want to make sure there are no tissue oocytes. The tissue oocytes. Make sure that, this fecal oral contamination by the cats, they excrete these oocytes, and they can stay there for something like 4 days. 4 days. After 4 days, they are infective. If they are taken by you, by humans, they can infect humans to cause toxoplasmosis. They can cause. So this causative agent is very important to know that the meat has got to be cooked properly. It must be well done, so to say. Well done. Then you're safe. then you're safe when it's well done. But when it is half done, you don't know if you are ingesting oocytes. And if you are ingesting this, you remember oocytes, when do you get them? You get them with the, the latent stage, the latent or the chronic stage of toxoplasmosis. There's an acute stage. In acute stage, you just get trophocytes there, trophocytes. And one has to know that these, we can do away with them by simply cooking, by simply freezing unused, or the meat that has not been used. Freeze it, they will die. Freeze it, they will die. When you cook it properly. Let it be well done rather than half done. Because you don't know if the oocytes are still there. You don't know that, right? So basically, this is what we need to be understanding. We need to say, this is a condition. What struck me here was the fact that when an adolescent, or shall I say a young man or a young lady, when they get their first job and whatnot, and they start convulsing that time, no one thinks of toxoplasmosis or try to find out whether there was toxoplasmosis here or not. Do some tests, do some serology tests, do some brain, find out if there's an infection of the brain. These patients, they go to an extent of develop encephalitis. They develop encephalitis. They develop delirium, this acute confusional state. They develop that. And when they develop those, no one ever thinks of Toxoplasma gondii, or toxoplasmosis as a condition. It's very, very difficult for people to think that way. We tend to do what is known as symptomatic treatment. When a patient is fitting, you stop the fit. And you think of nothing else but an epilepsy clinic. If it's a repeated seizures, you think of epilepsy clinic, and that's it. And no one ever thinks, hey man, let me investigate this patient. And let me investigate this patient for toxoplasmosis. And think of a way of eliminating toxoplasmosis. Think of eliminating the oocytes. Think of eliminating, the trophozoites. Think of elimination of this. Using what kind of treatment are we going to use here? We are going to use, sulfonamides. We're going to use the pyrimethamine. And we will always watch out for the bone marrow suppression of the when the pyrimethamines, of course they will do away with toxoplasmosis, but the bone marrow suppression, you have to watch out for that. And sulfonamides, you have to watch out this blood dyscrasias. You have to watch out that. And this is basically what we need to be understanding. And always watch out for the ocular toxoplasmosis. And when you think of the ocular, you think of the scotoma. The scotoma is a blind spot. And scotomata, many blind spots you know that blurred vision will come from that. Sometimes you get patients who lose their vision altogether. They lose their vision altogether. You know, others develop epilepsy instead of just one convulsion or one seizure. They develop epilepsy. You know, this is you know, when you have those conditions, one now that one is knowledgeable about toxoplasmosis, should think about toxoplasmosis. Should think about toxoplasmosis. Once you see a patient who loses vision, think of ocular toxoplasmosis. Think of ocular toxoplasmosis. Once you see a patient who develops, yes, this infant who develops hydrocephalus, who develops microcephalus, one is to think of toxoplasmosis or toxoplasma gondii infection, is to think of a localized one. And when you have this funny headache, this sore throat, this fatigue, you know, they say they develop mononucleosis-like syndrome. You know, the fatigue, the headache, those are myalgia, malaise, those are monocyclosis. Monocyclosis like syndrome. It's a syndrome. It looks like, or a cluster of conditions caused by this. And this monocyclosis, you remember, is caused by it's a viral infection, Epstein-Barr virus. So you develop a condition formed by you develop symptoms or a condition caused by this mononucleosis, which is caused by the Epstein-Barr virus. But now you start seeing something like that in toxoplasmosis. So toxoplasmosis can encompass a lot of conditions, and one has to be aware that no, this is toxoplasmosis. This is not mononucleosis. This is not mononucleosis. This is toxoplasmosis. It's just that these are mononucleosis-like syndrome, the mononucleosis-like syndrome, but it is in toxoplasmosis. Thank you very much. Thank you very much.